So my name is Derek, and I'd like to speak to you about transformational healthcare, the human capital of the future. So specifically, I want to talk to you about, in this evolving, changing world, how we ensure that the next generation of doctors and clinicians have the skills and abilities to operate in that world at the highest point of their potential to improve patient care. I work as a consultant physician or doctor in Ireland in the hospital, University Hospital Galway, and I'm Professor of Medical Device Technology at the National University of Ireland, Galway. So I am a physicianeer. And what that means is I'm somebody who's been trained in both medicine as a physician, but also in engineering. So those who practice medicine know that it's always a spectrum of color. There's lots of clinical problems with no easy solutions. But those who train in engineering, they think very black and white. They're very logical and they're solutions orientated. So when you have training and experience in engineering and also in medicine, you can come up with creative innovation solutions for clinical problems at the bedside. And that's what a physicianeer is. Now, it took a lot of training to become a physicianeer, 20 years of training in medicine and engineering, postdoctoral science work at Harvard, clinical fellowship at the Mayo Clinic, 20 years of clinical training and a lot of exams. And when I got my permanent job in 2018 in Ireland, after all that study, my father cried. He was so happy that I was finished college and that I was finally working. So as a physicianeer, in my laboratory in Ireland, I see patients in the hospital, and then I have a laboratory where we develop innovative solutions. So we develop, for example, drones that deliver medicine beyond the visual line of sight, or BVLOS. During the pandemic, we developed ventilator splitters because we had the expertise in our Hive lab, health innovation via engineering. That laboratory is full of people with multiple skill sets. You have scientists, engineers, psychologists, educationalists, and clinicians, all working together, busy in the Hive. And that's really important. As you'll see in this picture, we actually have robots. To misquote Star Wars, these are the robots and droids you're looking for. One of the robots, Super Mario, was used during the COVID-19 pandemic as a telepresence to bring pediatric patients who were in hospital closer to their families at home who weren't allowed visit because of the restrictions. The other robot, Dave, we programmed to remind people as they came into the hospital to wash their hands for hand hygiene. And also we trained Dave to teach people about chronic disease management, such as diabetes. So we use robots in our clinical practice and lots of other examples of engineering in medicine. So this talk is about the 3 T's of the next generation of doctors: the amazing talent that we need in the people, the advanced technology, and the human touch. But humans, they evolve slowly, whereas technology evolves very quickly. And then there's often a mismatch. And if you think of the technology that's changed our society in the last 20 years, in shopping and in banking, healthcare has been one of the slowest ones to adopt change. And that's because the premise of medicine, the central tenet of medicine, is primum non nocere, which is firstly, do no harm. So in medicine, we're slow to adopt change typically because of maybe unforeseen consequences later on down the line. And that's why it's been delayed. But we're not the only industry where that has happened. And I'd like to share with you a story of a project that I worked on with NASA where we put a bio-vest on astronauts in space. And the experiment about 15 years ago, it cost $50,000. And I needed to put it in space on the space station. And when I went down to the post room of the university and I said I needed to ship this, they said, oh, it's more than $10,000 our normal insurance package. Therefore, you're going to have to get special codes for it to be shipped and covered. So I rang the insurance company and I said to them, I need to ship this package out of Ireland. I need to get special codes from you. So the lady on the phone went to her computer and was like, click, 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 click. Okay, sir, where are you shipping it? And I said, we're shipping it from Ireland to the Netherlands by aeroplane. And then she typed in click, 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 click. And she came back and said, that's code 6434, put that on your form. So I put that down on the form. And then she said, where is it going then, sir? And I said, it's going from the Netherlands to Kazakhstan, to the aerodrome. And she looked on her computer and typed click, 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 and then said over the phone, that's code 44321, enter out of European airspace. And I said, okay, so I wrote that in the form to make sure it was covered. And then she said, where's it going then, sir? And I said, from there, then it's going into outer space. And there was silence on the phone. And then she said, oh, we don't have a code for that, sir. And it was a great example of the technology passing out the traditional way that the insurance world worked. And it was a great opportunity then for innovation. Just like drones are now for delivering medicines, back then it was about putting payload into space. And we've seen now that more and more people are putting payload into space. So what's behind this? So if you look at this picture here, these are lots of different discrete devices. And up to about 15 years ago, January 2007, all of these devices were separate. But suddenly they became integrated into a single supercomputer in your pocket, the smartphone. And over the last 15 years or so, we've had this digital Cambrian explosion of technology in our world. So for those geologists in the audience, the Cambrian explosion was about 530 million years ago, when there was a massive change in life on Earth because of rising oxygen levels. And it's recorded in the fossil record. And when we look back in the future to this period of human life, we're going to say, wow, what happened then that allowed them to have all this digital technology? And the answer primarily is Moore's law. Gordon Moore, who founded Intel, realized that every 12 to 18 months, the density of transistors that you can put on a piece of silicon doubles. And that means you can double the memory capacity and the processing power. And it kind of explains why every year there's new phones and new televisions and so on, and why it takes about a year for new stuff to come out. And it's transformed our society, the computational power, the storage power of these tools across all sectors. And in healthcare. So in healthcare, we have great examples of technology in the surgical suite, as we've just heard, in the radiotherapy suite, in the radiology suite, in chronic disease management. Diseases such as diabetes have been transformed in the last 5 years with insulin pumps, with continuous glucose monitors, with data analysis of that. But it hasn't been encompassed into the teaching of the undergraduate students around the world. And that's a problem. When you go to medical school now, you have the same syllabus as you used to have: anatomy, physiology, pharmacology, but they need another module. They need one in technology. They need to understand the tools, and more importantly, the limitations of the tools, so that they can help patients. But these tools should not replace the third T, which is the human touch. And that's a problem sometimes that we do hear about technology, that it'll be nameless between the doctor and the patient because the technology will do all the work. But the paradigm, you should think of something like banking. So most of banking now is done digital to digital. And in the future, healthcare will be done digital to digital. But now and then you still have to go into the bank to sign some documents and be seen. And the same thing in healthcare, you'll still physically have to go in now and then to actually get some major diagnostics done or operations. But it has transformed the way we practice medicine, and it isn't going to change. And the technology, rather than being a barrier, will actually enable patient-centered care. So you can see here these surgeons planning an operation using augmented reality. We use these tools now when we educate students in the progressive medical schools of the world using simulation technology. The old adage of clinical medicine used to be see one, do one, teach one. Whereas now before that we have simulate one. So students have practiced a lumbar puncture 5, 10, 20 times before they ever do one on a patient. And that's really important. It empowers the students to be better doctors and has better outcomes ultimately. So technology will enable this patient-centered care. And it's going to be the future of the way that we practice medicine. Now, when you think of the technology, you think of the tools that are out there. So we hear artificial intelligence mentioned a lot as a byline for the technology. And really what they're talking about is a subset of artificial intelligence, which is machine learning. So you see an example here of a retina. So if you looked into the back of somebody's eye, this is what you'd see. And recently, researchers have shown that not only can they identify the disease at the back of the retina as good as a consultant physician, an ophthalmologist, they can also tell the sex of the patient, if they're male or female. And there's no consultant ophthalmologist on earth that can look into the back of the eye and tell the sex of the patient, which means that the AI tools are seeing something in the data that's just beyond our comprehension. Now, as a doctor, I can tell you there's easier ways to tell the sex of a patient than looking in the back of the eye. But the principle is that the data can be assessed at a more granular level by the actual AI tools. And not only is it in ophthalmology, it's been shown in electrocardiograms. They can see the same arrhythmias with better granularity than consulting cardiologists, but they can also tell the age and sex of the patient by the actual scan. We've seen this as well in big data clusters. So in diabetes management, not only can you look at the data in a continuous glucose monitor and tell that someone's going to have a low blood sugar or a hypoglycemia in the next 15, 20 minutes, you can actually use AI tools to say this person with this pattern over the last few hours will have a low blood sugar event in 8 hours' time. So the prediction window is getting wider because of the AI tools. COVID-19 is a massive health crisis, as we all know, but it also has been a digital catalyst. So we say in medicine that 10 years of digital transformation happened in 1 year because of COVID-19. Overnight, we suddenly had to figure out how to manage patients remotely. So the easiest examples was just to use the telephone or video consultations such as here, like Remote Care 1.0. Remote Care 2.0 allowed us to see patients, but then also see that real-time data as well. So for example, at my clinic, we were able to see the patients and also see all their blood sugar diary. So suddenly we're able to see all their blood sugar excursions while talking to the patient and able to say, I see on a Tuesday morning your blood sugar is going low in the last 2 weeks. Why is that? And then the patient's able to say, oh yeah, I recently started jogging. And then we could have a rich discussion about how to adjust their insulin and so on. So it really enabled the care by having the data from their physiological monitoring, like we did 15 years previously with the astronauts, but now it's at the clinic because of Moore's Law, because of the digital explosion. The next version of this will allow dynamic consultation. So when I see a patient at my clinic, like many of your doctors, I talk to the patient, I assess their status, and based on all the data I have now, I say, okay, I'll see you again at my clinic in maybe 9 months' time. Or if I'm worried about them, maybe in 3 months' time. And it depends on the data that I have now. But I've always wondered, when a patient walks out the door, I have no idea what happens in their life, with their medical condition. And so what we're trialing now at my lab is dynamic consultations, whereby the AI looks at all the physiological data and then is able to dynamically give them an appointment sooner if it is needed. So this world of connected health and data overload that we have, the next generation of doctors, as well as the traditional skill sets that I outlined, they also need to be critical thinkers. And we really saw this during the COVID-19 pandemic with so much fake news out there. They needed to be able to say, where is this information coming from? Is it valid? And then also, if it is valid information, is it enough information? Was the trial that was done on the right cohort of patients as the patients I have in front of me at my clinic? Was there any confounders? What are the limitations of the studies? These are the kind of skills we traditionally taught at universities around the world in postgraduate teaching. But now that needs to come into medical schools to ensure that our doctors of the future are able to critically analyze the evidence-based medicine that they practice. And this brings in the concept then of extended intelligence. So we've heard of artificial intelligence, we've heard of human intelligence, but then there's extended intelligence. And there is some apprehension among doctors and patients that technology will be an antithesis to that. But actually, in the future, technology will complement, not compete with doctors. It will improve the care they give patients. The extended intelligence will mean that doctors can be better doctors because they have access to more information. So when they go to make a decision, they're able to access online repositories such as UpToDate, because those repositories are kept up to date in those subspecialist areas far better than any individual physician can do. So by accessing that, they're extending their intelligence. By having AI tools to dynamically appoint their patients to come back again, that's extended intelligence. By having AI tools screen patients for different diseases, that's extended intelligence. So ways to improve patient care with the technology. Now, this is really important because it allows future doctors, nurses, and so on to operate what I call higher up their license. And I've given talks about AI, about, as I mentioned earlier, that it's able to diagnose the image-based specialties, especially recently. So ophthalmology, pathology, dermatology, radiology. That's been shown quite convincingly that you can train a computer on a data set in a morning that might take an individual a lifetime to see that number of cases. And the actual machine learning algorithm can get results that are as good as a consultant in that area. In my own lab, we did it recently, showing that we could look at thyroid nodules from an ultrasound and be able to classify it as benign or malignant, as good as a consultant radiologist. And that's a game changer, because in the old system, to get the best medical care in the world, we'd all want the best radiologists in the world to look at our scans. You probably have to go to one of the great university teaching hospitals of the world. But if the AI can do it, that goes a long way to the WHO and UN goals of health for all, because now you can put that software in an ultrasound probe, and you can use that ultrasound probe anywhere in the world, and you'll get the answer, benign or malignant, as good as somebody working at the major health institutions. When I gave a talk recently to the World Dermatology Forum, and I explained to them some of the data, that you can now take pictures of nevi or moles on your hand, and the AI can classify it as benign or malignant, as good as a dermatologist. There was silence in the room, because all these clinicians were wondering, oh my goodness, the computers are going to come and take our jobs. We don't need to be referred anybody anymore. And I said, no, it's the opposite. This is a good news story. Every week as a specialist in the hospital, you get 100 referrals a week for a query skin cancer. And you've got to sort through 90 of them to find which 10 are the ones are the true skin cancer or melanoma. And then you call those patients in and you see them quickly in your clinic to treat them. But now with extended intelligence and these AI algorithms, you're only going to get referred maybe 20 patients a week, because it will have screened the other 80 out as not suspicious. And therefore those 20 that you see, then you're going to get the 10 out of it and see them. And that will enable you more time to spend with those patients. And it's also important to point out that the AI has limitations. It's just pattern matching the machine learning with the pictures. But it's not able to get the data that you are as a clinician, for example, personal history of cancer, family history of cancer, risk factors, things that would increase the likelihood of that lesion being suspicious or not. And that's really important to remember, that as a doctor, as a clinician, you bring a lot more to the table than just actually spotting something on a skin lesion or on a printout of a graph from a machine. And so you can spend more time with the patient, explaining to them about their condition and giving them the options, enabling patient-centered care. When you look at some of the programs around the world that do really well with the dual medical engineering program, you're looking at the Harvard MIT program, the HST. You're looking at Northwestern University in Chicago, which has a dual engineering medical program. The National University of Singapore, in partnership with Duke University, has a very strong medical and engineering program together. And in Galway, where I work, we've recently launched Europe's first medical engineering program to create a new cadre of physicianeers of the future. But besides these courses that go into a lot of detail in engineering and medicine, in the regular medical schools of the world, there is a mandate now, I think, for technology to be taught at the medical school level, that our clinicians of the future does have the vocabulary and it knows the tools to use for the patients. And that's what transformational healthcare is. It's about the talent, the amazing talent in medicine. It's about this medtech technology, and it's about the human touch that's enabled by being able to spend more time with your patients. And because of this, we have better patient-centered care. We enable the technology and AI tools to be used at the bedside. We have a new generation of clinicians that are critical thinkers and don't just accept things, they query things. They operate extended intelligence because they use the tools to their advantage and for their patients' benefit. And that allows them to operate higher up their license for all that training that they did to be better clinicians. And I'm going to leave you now with this phrase, ancora imparo. So this phrase was uttered by the great Michelangelo Buonarroti, the Renaissance scholar and artist. And he reputedly said it in his 80s on one of his birthdays, when one of his students who was working with him, one of his apprentices, told him something and he didn't know it. And he turned around and he said, "Ancora imparo." I am still learning. And I think that's very important. As I mentioned earlier, we all have different lenses on the world. So traditional medical schools are just clinical, traditional engineering schools are just engineering. And it's by being exposed to other inputs and other expertise is where you can find real innovation in the cross-pollination of the two. And to continue this journey, I recently undertook an MBA. Don't worry, my father didn't cry again. It's part-time. But the reason I'm doing it is to learn the skill set of the business world, because again, in the modern hospital, doctors operate as part of complex teams. And so that's very important to understand, both for my medical students and then ultimately for patient care. Thank you very much.